Every clinical framework has characteristic blind spots. They do not emerge from where the framework is weak, but from where it is strongest. Field-based formulation is a powerful diagnostic orientation. It prioritizes relational connection and works systematically to depathologize severe human distress, shifting the focus from rigid categorical diseases to dynamic processes of meaning. Because the framework is highly effective at interpreting symptoms as a process to be understood, rather than an endpoint to be suppressed, it creates a systemic gravitational pull. Practitioners begin to see all pathology as a crisis of meaning, risking the dangerous undertreatment of severe organic medical crises. To counter this, a clinical tradition requires an inside critique. It must map its own failure modes, generated from within its own logic, to expose exactly where the practitioner is likely to misapply the tools. Consider the framework's core heuristic to enhance a patient's native capacity before resorting to pharmacological suppression. This is highly effective as a starting hypothesis. It becomes dangerous when clinicians elevate it to an absolute rule. We are going to map out 6 distinct ways this framework fractures in practice. By identifying the clinical markers for each error, we can weigh their consequences and establish the specific decision rules required to deploy these tools safely. A clinical methodology that cannot explicitly name its own failure modes ceases to be a tool. It calcifies into an ideology. The first structural error is the kinesis capture failure. This chart maps the tension inherent in the capacity formulation. Clinicians are trained to prefer relational containment over pharmacological constraint. We see the slow, gradual curve required for relational containment plotted against the sharply spiking line of an acute biological harm. When a patient presents with acute psychotic agitation or active command hallucinations, the stress escalates rapidly. The immediate threat to life outpaces the gradual timeline required for relational dialogue to take effect. The decision rule here is strictly temporal. When the timescale of biological harm is shorter than the timescale of relational containment, rapid pharmacological stabilization takes absolute precedence. If a patient is experiencing command hallucinations to harm themselves and has refused food for 3 days, attempting to de-escalate through a family network meeting is the wrong protocol. The situation demands rapid tranquilization. Using medication to stabilize the field in an emergency does not violate the framework's ethos. Pharmacology provides the required physical scaffolding. It stabilizes the biological substrate so that relational work can actually resume once the acute crisis has passed. This brings us to the transformation program misread, an error where catastrophic biological collapse is romantically interpreted as a psychological breakthrough. Clinicians look at an H<0 state, a phase of profound psychological dissolution, and apply the insight that these states can resolve into a higher integration. A patient may present with elaborate cosmic delusions that feel highly meaningful. If a clinician is captivated by the phenomenological richness of that experience, they might treat it as a spiritual emergence, while completely missing the actual driver, like autoimmune encephalitis. The operational rule is clear. Full physical examinations and organic exclusions must be completed before any formulation-level interpretation begins. This misread shares a root cause with the G overload failure, where a practitioner assumes that a robust network of relational support can heal a purely biological crisis. Severe melancholic depression and mounting catatonia, or delirium tremens, cannot be held by a supportive environment. They require targeted medical interventions like electroconvulsive therapy or lorazepam. The biological substrate operates on its own unforgiving timeline. It is completely indifferent to the quality, depth, or empathy of the surrounding relational field. Honoring a patient's subjective meaning-making is a core clinical duty, but allowing that respect to mask a progressive, potentially fatal organic driver is clinical negligence. The third fracture is the wild-type capture. The framework accurately observes that certain cognitive architectures are not strict disease entities. Genetic variations often index a hypersensitivity to specific environments. A person doesn't necessarily have a deficit, they are mismatched with their surroundings. This matrix plots environmental support against functional capacity. A data point remaining in the low function quadrant despite maximum support reveals a persistent impairment. The error occurs when clinicians generalize the ecological reframing to deny the reality of this exact functional breakdown in conditions like ADHD. To test the wild-type hypothesis, we observe the data. If severe impairment persists across multiple domains despite maximum environmental support, the wild-type frame is the wrong hypothesis. For these patients, targeted medication does not artificially substitute missing skills. Stimulants act as a capacity-revealing intervention, clearing neurobiological interference so the patient's native capacity can finally express itself. Clinicians often harbor a strong preference for avoiding diagnostic labels and pharmacological interventions to prevent stigma. But this framework preference must never override a patient's own stated request for symptom-targeted relief. Denying an effective, evidence-based intervention to maintain a stance against pathologizing is a direct violation of patient autonomy, disguised as theoretical purity. We see a similar ideological bias in the iatrogenic incapacity attribution error, the automatic assumption that any poor outcome on medication is caused by the medication itself. This bell curve represents aggregate population outcomes, confirming through epidemiological data that the apparent chronicity of some severe mental illnesses is driven by long-term medication dependency. The data shows that a proportion of the population would do better off maintenance medication, but the failure mode takes this aggregate population-level finding and applies it as a generic top-down rule to an individual patient. A practitioner operating under this bias might counsel a patient to discontinue life-saving maintenance lithium, entirely ignoring that individual's documented history of severe, destructive manic relapses when unmedicated. This leads directly into the CL suppression conflation. This is the mistake of reading all symptom reduction as an inherently negative suppression of the patient's psyche. The same molecule can act as a blunt constraint in one patient, dampening their environmental sensitivity, while acting as vital scaffolding in another, reducing rumination just enough to allow reflective capacity to return. A medication's true function cannot be predetermined by its chemical class, whether it is a poison that suppresses the mind or the scaffolding that enables trauma processing, is dictated entirely by the specific clinical field it enters. These technical errors point to a deeper structural threat, the second-order failure where the framework calcifies into the practitioner's personal and professional identity. The clinical tool mutates into an in-group tribal marker. Practitioners use it primarily to signal their intellectual sophistication and define themselves in opposition to mainstream categorical psychiatry. This manifests clinically as semiotic capture. Instead of listening to the reality of the patient's experience, the clinician hijacks their genuine distress and aggressively reframes it into the framework's bespoke theoretical jargon. When a clinician forces a patient to adopt specific, highly theorized language just to be heard, they replicate the exact clinical violence they originally diagnosed in mainstream psychiatry. The framework was designed to be a temporary node in the explanatory process. It is a tool to assist the patient, not a permanent destination to validate the practitioner's ego. When the ideological boundary between us and them does more work than the actual clinical encounter, the practitioner has abandoned the patient for a theory. Systematically naming these fractures is not a retreat. It is the exact mechanism required to harden the tradition against its valid critics. Mainstream medicine rightly warns that field-based approaches risk the undertreatment of severe illness. A framework mature enough to document its own failure modes is the only kind that can be safely trusted to manage high-acuity patients. Adopting the framework is merely the beginning of the work. The architectural map is not deterritory, and continuous active discrimination is required in every single clinical encounter. For the practitioner, the mandates remain clear. Regulation must precede recursion. There can be no psychological expansion without secure biological embodiment. The ultimate operating principle of field-based formulation is simple. The reality of the patient in front of you must always precede the purity of the framework.